This presentation will describe the processes that are involved in the regulation of blood cell formation, looking at erythropoiesis, the haemoglobin structure and anemia. It will also include an overview of normal haemostatic response, outlining the coagulation factors, specifically looking at platelets, thrombocytopenia and coagulation disorders. Blood cells for lifelong haemopoiesis cannot be preformed in the body, hence we need a renewable source. This highly regulated production process occurs in the haemopoietic tissue and responds to many physiological changes. There is a very high cell turnover involved, and the production of new cells at a rate of 10 to the power of 11, 10 to the power of 12 is required per day to maintain steady blood counts. In this slide you can see that haemopoiesis occurs in phases. During the embryonic phase from 0 to 2 months, the main site is in the yolk sac. At 2 to 7 months, the fetal hepatic phase occurs with the development of alpha and gamma chains as the liver and spleen slowly take over to become the dominant sites of blood cell production. The bone marrow eventually takes over towards the end of gestation at 5 to 9 months, so that at birth this is the dominant site. There is a gradual switch from gamma to beta chains at this time. In infancy, it involves the bone marrow of practically all bones. As the child develops, haemopoiesis occurs in the marrow of the long distal bones, such as the femur and tibia. In adults, it is the bone marrow of the central skeleton, the vertebrae, ribs, sternum, skull, sacrum, pelvis and proximal ends of the femur that are the main sites. Within these haemopoietic sites, 50% of the marrow consists of fat. This fatty marrow is capable of reversion for haemopoiesis and may expand down the long distal bones during some disease processes. In some cases, the liver, thymus and spleen may resume their fetal haemopoietic function. This is called extramedullary haemopoiesis. It may cause these organs to increase in size substantially, for example in splenomegalia. This diagram demonstrates the stages of development of various cell types. The haemopoietic system is a hierarchy of increasing cell commitment and differentiation. It starts with the pluripotent haemopoietic stem cell that can self-renew but also gives rise to lineage-committed progenitor cells. The pluripotent stem cell differentiates into one of two types of common progenitor cells. The common myeloid progenitor lineage includes red blood cells, platelets, macrophages and neutrophils, responsible for tissue nourishment, oxygenation, blood viscosity, coagulation and immune functions such as innate and adaptive immunity. The common lymphoid progenitor lineage includes T cells and B cells, which provide the foundation for the immune system. Pre-B cells and pro-thymyocytes finish their development in the lymphatic tissue after leaving the red marrow. The common lymphoid progenitor lineage includes T cells and B cells, which provide the foundation for the immune system. Pre-B cells and pro-thymocytes finish their development in the lymphatic tissue after leaving the red marrow. The progenitor cells divide to generate cell production. When they can no longer divide, they give rise to committed cell units called colony-forming units, leading to specific cell series. As shown on the slide, the CFU-E develops into red cells. The next generation are the blast cells. These have recognisable histological characteristics, which then develop with several divisions into the mature cell types. The bone marrow forms a suitable environment for stem cell growth. It is comprised of stromal cell and a microvascular network. Stromal cells provide a specialised adhesive microenvironment in which stem and progenitor cells are embedded. Blood vessels surrounding sinuses facilitate and regulate release of cells into the circulation. For a given time in their development, stem cells express the chemokine receptor CXCR4, which is responsible for anchoring stem cells to the bone marrow microenvironment. Subsequent processes, proliferation, differentiation, migration and death of stem cells and their progeny are controlled by external cues provided by this microenvironment. Some examples of haemopoietic growth factors are erythropoietin, the stimulating hormone for erythropoiesis, and thrombopoietin, a hormone from the liver which stimulates megakaryopoiesis. i.e. the formation of platelets. Artificial growth factors like EPO, available through recombinant DNA technology, can be exogenously administered in an effort to treat decreased red blood cell production in end-stage kidney disease. Cytokines are local hormones of bone marrow produced by some marrow cells to stimulate proliferation of other marrow cells of colony-stimulating factors, and interleukin to stimulate white blood cell production and enhance the yield of stem cells, e.g. granulocyte macrophage colony stimulating factor, or GM-CSF, and the macrophage colony stimulating factor of MCF. What influences the capacity for the pluripotent stem cell to self-replicate and differentiate along several different lines? As the diagram shows, it is three interlinked processes. The stromal microenvironment allows stem cells to grow and divide. Humoral substances or hemopoietic growth factors stimulate or suppress proliferation of single or multiple cell lineages. Cells in the different tissues of the body can signal the need of different levels of cell production, e.g. anoxic conditions lead to the production of erythropoietin. Interleukin-3 or IL-3 is a multi-specific growth factor that stimulates early progenitor cells. There is also a balance between cell production and cell death. The cell cycle is a complex process at the heart of hemopoiesis. The duration of the cell cycle is variable for different tissues, but the basic principle is the same. The cell physically divides. This is called the meiotic phase. There is then the duplication of chromosomes and cell growth, i.e. the interphase, then programmed cell death, apoptosis, occurs. Any dysregulation of cell proliferation death can also be a key factor in the development of malignant disease. Erythrocyte formation, called erythropoiesis, occurs in adult red bone marrow of certain bones. We produce 10 to the power of 12 new cells each day. The body does not have preformed stores. Stimulus for production is hypoxia, the oxygen tension in the kidney tissues. If hemoglobin can't give up oxygen or oxygen delivery to kidneys is low, erythropoietin production increases and stimulates erythropoiesis, particularly the development of proerythroblasts and reticulocytes. This slide demonstrates the erythropoietic process. On day 1, the proerythroblast starts to produce hemoglobin. By day 3, the basophilic erythroblast and the polychromatophilic erythroblast development is complete. On day 4, the nucleus is rejected from the normoblast and the reticulocyte is formed. During days 5 to 7, the reticulocyte escapes from the bone marrow into the blood. It ejects the remaining organelles and the mature red blood cell is formed. The flexible biconcave shape is to allow the red cell to repeatedly pass through the microcirculation, carrying the specialised protein hemoglobin into close contact with tissues and facilitating successful gaseous exchange in the tissues. There is no capacity for cell division or repair due to a lack of a nucleus and organelles. We make around 10 to the power of 12 new erythrocytes each day through the process called erythropoiesis. Worn out cells are removed by fixed macrophages in the spleen and liver. This slide depicts the hemoglobin molecule structure. Hemoglobin concentration is influenced by many factors. It is the total red cell mass that contributes to the oxygen transport capacity, not the hemoglobin level. Other factors such as cardiac output, pulmonary function, oxygen binding coefficient and the demand of tissue are also important in determining oxygen delivery. Reduced hemoglobin in the red blood cells due to any abnormality of its constituents results in a clinical situation called anemia. The physical response to anemia is usually a drop in hemoglobin accompanied by a drop in red cell count and packed red cell volume, although it may be normal in some patients. In cases of dehydration, the decrease in plasma volume may mask anemia, and during pregnancy, the increase in plasma volume may indicate anemia despite a normal circulating red cell and hemoglobin mass. In cases of major hemorrhage where there is a reduced blood volume, anemia may not be apparent immediately. The speed and severity of anemia can influence the response. Rapid onset may cause more acute symptoms as the body has less time to adapt. Mild anemia may cause no symptoms. Elderly patients may tolerate anemias less well due to reduced oxygen to the organs when normal cardiovascular compensation is impaired. There is increased stroke volume and tachycardia and an already increasing cardiac output. Anemia is not a diagnosis. It is an abnormal clinical finding that needs an explanation for its cause. Transfusion is often a knee-jerk response to anemia. You have to look at the clinical picture, not just the lab results. This slide lists the tests that can be utilised to determine the degree and type of anemia. The reticulocyte count should be 0.5 to 2.5% of the circulating red blood cells. It should rise in cases of anemia and be higher the more severe the anemia. A low count in an anemic person might indicate impaired marrow function, an acute leukemia, tuberculosis or myeloma, or a lack of erythropoietin may indicate renal disease. There may be ineffective erythropoiesis, as in cases of thalassemia major and myelodysplasia, or it may indicate an iron deficiency, i.e. a vitamin B12 or folate deficiency. A high count might indicate recent blood loss or successful iron therapy. Measurement of changes in the leukocyte and platelet counts can help distinguish a pure anemia from pancytopenia. Blood films should be examined in all cases of anemia. Abnormal red cell morphology may suggest a diagnosis. It must also be stressed that it is important to look at the clinical picture, not just the lab results. Anemias are classified according to the size of the red cells, as shown in the table on the slide. Of the hypochromic anemias, the most common worldwide is iron deficiency. It is also seen in chronic inflammatory disorders and malignant diseases. Normocytic anemias include the hemolytic anemia disorders. These can be due to an inherited red cell defect or due to an acquired cause, usually an abnormality of the red cell environment, but shortens the life of the red cell. The red cell may break down in the reticuloendothelial system, i.e. extravascular, or in the circulation, intravascular system. Features of extravascular hemolysis include raised reticulocytes, jaundice, gallstones, and splenomegaly. Acquired hemolytic anemias can be autoimmune warm or cold antibody productions or alloimmune reactions such as a blood transfusion reaction or hemolytic disease of the newborn. They may also be drug-induced, e.g. dapsone, and can also be caused by infections such as malaria or Clostridium. It may also be seen in patients with extensive burns, DIC, or paroxysmal nocturnal hemoglobinuria. It can also be seen in patients with red cell fragmentation syndrome, where red cells are damaged on the abnormal surface due to heart valve grafts, etc. Hereditary hemolytic anemias include red cell membrane dysfunction, as in hereditary spherocytosis, and metabolism dysfunction, as in glucose 6-phosphate dehydrogenase deficiency. It also includes hemoglobinopathies like HB sickle cell disease. Microcytic anemias show an increased size of circulating red cells and include the megablastic anemias, where the erythroblasts show delayed nucleus development, as in cases of B12 deficiency. Before transfusing, consider causes of anemia. Autoimmune hemolytic anemia. Avoid a transfusion if possible. Often unable to provide matched blood, and there is a risk of exacerbating hemolysis. In B12 or folate deficiencies, avoid transfusion due to the risk of circulatory overload. With iron deficiency, iron replacement will increase the hemoglobin by 2 grams per decilitre in 3 weeks. In bone marrow disorders, there is a limited capacity for the hemoglobin to recover. The coagulation process that leads to hemostasis involves a complex set of protease reactions involving roughly 30 different proteins. The final result of these reactions is to convert fibrinogen, a soluble protein, to insoluble strands of fibrin. Together with platelets, the fibrin strands form a stable blood clot. For decades, the coagulation cascade was conceptualised as having two semi-independent points of initiation, labelled the intrinsic and extrinsic pathways, as per the diagram on the slide. The intrinsic pathway triggered when contact was made between blood and exposed endothelial tissues, a relatively slow process of approximately 2 to 6 minutes. The extrinsic pathway, triggered by vessel damage which led to the exposure of tissue factor, is quite a fast process, approximately 15 seconds. Both pathways lead to the activation of prothrombin, factor 2, and the final common pathway converting the fibrinogen to fibrin. Over time, it has become clear that these pathways do not function in the body as parallel independent systems. This finding that the tissue factor, factor 7A complex, from the extrinsic pathway activates factors in both systems suggests that they are linked. This discovery, combined with an evolving understanding of the role of different cells, in particular platelets, has led to a cell-based model of coagulation. Unlike the older intrinsic-extrinsic cascade, the cell-based model includes the important interactions between cellular activity and the coagulation proteins that lead to blood clot formation in hemostasis. The hemostatic process ensures blood remains fluid and contained within the vasculature. The normal hemostatic response to vascular injury depends on a complex series of interactions between the blood vessel wall, circulating platelets, coagulation factors, and coagulation inhibitors. If this goes out of balance, it can lead to significant morbidity and mortality. There are 3 distinct phases. Primary hemostasis involves constriction of the damaged vessel, restricting blood flow, with the damage to the vessel wall exposing subendothelial proteins, most notably von Willebrand factor, secreted by the endothelial cells. This factor recruits factor 8, other clotting factors, and collagen. The circulating platelets bind to the collagen via specific glycoprotein receptors on their surface. This activates platelet aggregation, the adhesion of platelets to the vessel wall and other platelets. These adhesions activate platelet degranulation, whereby platelets release their stored granules, including serotonin, platelet activating factors, and thromboxane, into the plasma. Thromboxane potentiates platelet aggregation as well as the vasoconstrictive action, thus limiting leakage of blood. In secondary hemostasis, the platelets change shape, open up their membrane and become more spherical to provide a large reactive surface to which plasma coagulation proteins may be selectively absorbed. This simultaneous platelet activation and aggregation plus enzymatic reactions involving coagulation proteins generates fibrin. The third phase, fibrinolysis, will be discussed on the next slide. The hemostatic system is a fine balance between procoagulant and anticoagulant mechanisms, keeping blood fluid and preventing excessive clot activation that can lead to intravascular thrombosis. Normal coagulation requires vitamin K and also involves clot retraction, i.e. the tightening, and fibrinolysis, the dissolution of clot, once damage has been repaired. Once the vessel damage is repaired, the fibrinolytic system dissolves small inappropriate clots and clots at the site of damage. Plasmin can dissolve a clot by digesting fibrin threads and inactivating substances such as fibrinogen, prothrombin, and factors 5, 8, and 12. Thrombopoietin, produced by the liver and kidneys, is the regulator of platelet production. It increases the number and the rate of maturation of the megakaryocytes. Platelet production starts with a hemopoietic stem cell and develops through the megakaryoblast and megakaryocyte stages, with the fragmentation of cystoplasm into mature platelet. Levels are increased in thrombocytopenia and reduced in thrombocytosis. Failure of platelet production may result from an inherited or acquired cause, including drug toxicity, viral infection, or general bone marrow failure. Disorders of platelet function are suspected in patients if there is prolonged bleeding time, with or without skin or mucosal hemorrhage. in the presence of normal platelet count and normal levels of von Willebrand factor. Acquired disorders most commonly seen in the use of antiplatelet drugs like aspirin and dipridamol. Clinical manifestations of thrombocytopenia can include petechia, ecchymosis, purpura, mucosal bleeding, menorrhagia or intracranial hemorrhage. Uncommon but the most feared. Thrombocytopenia is not seen in haemophilia or von Willebrand's disease. As this slide shows, there are two main reasons for thrombocytopenia, either increased consumption or failure of production. There are certain contributory factors that you may need to consider, which are on the next slide. Does the patient have symptoms or signs of liver disease? Is there a reason why the patient should be vitamin K deficient? Is there malnutrition, biliary obstruction? Are they on broad-spectrum antibiotics? Does the patient have a coexistent systemic disease, like sepsis, disseminated malignancy, obstetric problems, burns or even a snake bite? Before transfusion of platelets, consider the contraindications. Platelets are not usually indicated in the following conditions: immune thrombocytopenia, post-transfusion purpura, although they may be appropriate if the patient is acutely bleeding, in which case specialist advice from a consultant haematologist must be sought. The PT measures extrinsic and common pathways. It is affected by low concentrations of fibrinogen, prothrombin and factors 2, 5, 7 and 10. The APTT measures intrinsic and common pathways, deficiencies in all clotting factors except 7, 13 may prolong the APTT. Abnormalities in results can be influenced by inadequately filled collection tubes, excessive tourniquet time and prolonged time from sample taking to testing. The coagulation screen assists in the identification of the following disorders. Please move on to the next slide. This table lists disorders that may be indicated by PT and APTT coagulation screen results. Coagulation disorders can be classified as either inherited, as in haemophilia A and B, von Willebrand's disease and other factor deficiencies, or acquired, as in liver disease, vitamin K deficiency, following massive transfusion or due to drug therapy with warfarin, heparin or thrombolytics. The investigations listed on the slide can assist with obtaining a comprehensive coagulation picture. Another important factor in gaining the full clinical picture involves noting the person's bleeding history, any history of prescribed and/or any over-the-counter medications, and any family history of bleeding. In summary, always ask yourself, what are your patient's blood counts telling you? What is the haematological defect? What is the most appropriate therapy for the patient?